Hello, everyone, and welcome to tonight's webinar, Comprehensive Physician and Practice Rehabilitation Training. At this point, I'd like to introduce our first speaker for tonight, Dr. Laxmaya Manchakanti. Dr. Manchakanti, if you're ready, the floor is all yours.
As I was trying to say before, which you couldn't hear, that this is our last conference for now. We will see if we need more. As time passes on, we will let you know in a few weeks. It's going to be very exciting today. We are going to talk about financial aspects, social media, quality and value, time management, and lecture with Senator Bill Cassidy. Bill Cassidy has been our champion in the Congress, has helped us to get HHS funding and multiple other aspects. We think that $20 billion is going to hit the banks tomorrow or day after. Meanwhile, there is still more money there, about $50 billion from the first program, $75 billion from the second program, so hopefully we'll get some of that too. Meanwhile, we got the results of our Burnout Survey. IPM physicians, as we always knew, are at high risk. Everybody is impacted by COVID. They're all very concerned, 78%. 60% have a negative outlook. Burned out now, just because of the COVID, 52%. And 55%, unfortunately, are ready to quit practicing medicine. Procedures-wise, 60% have stopped all the procedures. Only 0% are performing normally. 56% expect reduction in workforce. 100% expect reduction in collections. The causes of burnout, this is pretty important. EMR documentation is 73% cause, and RCM in-house, revenue cycle management in-house, is not very good, 67%. So those two will be the stress removers if we can get rid of the EMRs as well as the in-house billing coding. Majority of the doctors are over 55, that is 50%, and many of them are in long-term practice, like 89% or so have been in practice for more than 11 years. We do work long hours. Most of the physicians work long hours, some 61 hours or more. So let us look at this pandemic, how it has been affecting us. There are some good things to it too. I think we are only talking about the bad stuff. Like traffic accidents are down by half. Fewer accidents, fewer deaths, and they are even giving refunds on that. But we are not driving our cars. Gas prices will soon be under $1. This is what it used to be, around 57 cents in 1976. So they will go back to that. But converted to that, actually, we will be at much cheaper value. India sees a drop in mortality under lockdown. In Bombay, death toll is less. I was talking to my brother in our state. There have been about 29 deaths or so far because of the pandemic, but there are no accidents or other deaths. They used to die about more than 30 people every day. The telemedicine is going to be popular into future. Now, looking at this slide, the suppression, mitigation, do nothing, etc., I thought we entered into this dance phase yesterday. I'm hoping that it will, but it still has some problems there. We are not out of the woods. Looking at the statistics again, we are in 8th or 9th place in the world per million. We are 211 deaths per million. Even with Sweden, without any lockdown, they have 283 deaths per million. This is how we started. California started the first lockdown, but they still are not opening. Some of the states started much later. New York started on 22nd. Of course, they're nowhere close to be open. This is what they are looking at, the potential future. recurring small outbreaks, a monster wave, or persistent crisis. Scenario 1, this is what we are hoping for. There will be small waves as far as I can see. If we don't have any, that will be good. But scenario 2 is history redux. There will be one peak and then we will go down. 3 is the worst one, slow burn scenario. If everything breaks wrong, we just keep having outbreaks in this city. So return to normalcy. Is that ever going to happen? We won't be the same as October 2019 again. Our lives have been transformed in ways that we could not possibly have imagined. The word does not refer to a state of being normal, is normalcy. It came after the First World War during a presidential speech by Warren Harding. He said he was going to bring the country to normalcy. Other than that, nobody else uses this word. So what are we doing with ASIPP? We are working on HHS grants. As I said, some checks are hitting tomorrow, and we are hoping to get more money. Funding from CARES Act. We may need a second CARES Act or a third, fourth, or something. What they are going to give us in help is going to last only 2 months. And this crisis is going to last like 5 months, because 2 months no practice, 2 months with very low practice, and no collection for a long time. Some states it is 3 to 4 months. We have issues with Medicare Advantage, telemedicine, increased payments, fraud and abuse investigations. We are working on those to stop them and reduce them. Clinically, we have gotten risk stratification, opening checklist, communications, and we are working on facet joint guidelines as we speak. So recently, they announced that they are going to pay for telephone visits at an increased price level. It was 14 to 41, but we have to use these other codes for telemedicine visits. So, but payment is exactly same as if we are using the follow-up visits, regular EM visits. And these will be retroactively applied through March 1st and last until June 6th. We are looking for even higher about August 6th. We have been requesting them to extend. So patient volumes are down, as I said. People are furloughing and laying off employees, and most people are looking at this to last for a long time. This is a dangerous trend for private practices, so more people may be willing to go to hospitals. We recently sent a checklist and risk stratification for opening of interventional pain management practices. We would like to thank Ricardo Buenaventura, who wrote this article, and we modified it somewhat. This is the checklist. You have this. We sent you. This is the risk stratification, 2 documents which will be very helpful for you. And some states are saying that we can test all the patients or follow your association guidelines. If you have such language, this will be great. So in reference to our health care, there were already a lot of changes coming. They were expecting like 41% increase in premiums. Looking at this one, this was published long before all this happened. We are still, in 2029, we are still going to have 35 million uninsured, but more Medicare Part A and Medicare Advantage, 85 million. Now it is 67. But there is no change in ACA exchange or employer-sponsored coverage. They seem to stay the same. They're looking at, ever since Affordable Care Act or Obamacare passed, the premiums increased 54%, and deductibles increased 162%. So this is where the issue comes. So less coverage, more money. How much is COVID-19 going to cost? Trillions and trillions of dollars. But just looking at one patient, it would be like $88,000. So it could be much higher in some places. Just pneumonia itself is $20 million. We have all our training videos available. I would like to thank our board, membership, ASIPP staff, PMCA, ASCP, TCS. Special thanks to my family and friends for standing through these hard times. Devi, Shalini, Amol, Sudhir, Melinda, Cindy, Tony, Diana, Sagar, Trish, Amanda, Senator Cassidy, McConnell. He forgot to put Bozeman's name. He has been great, helpful. Representatives Barr, Bhushan, Comer, and our advocacy folks, Congressman Ed Whitfield and Jeff Mortier. President Trump, Seema Verma, they have been very respectful and receptive. They have been very, very nice. I have never seen any administration to be that receptive to different ideas. I also would like to thank Rick, Mahendra, Sairam, and many others. We also thank for unrestricted grants from Boston Scientific. Now we got today the news that Nevro will help us, and so is Medtronic. Now, you have this book, Coronavirus Made Simple, by Dr. Devi. You can purchase that. She will talk a little bit more about it in a few minutes. Now, we will have Amol talking about financial issues. Amol?
Yes, thank you, Dr. Montacani. Great lecture and a wonderful slide deck full of information. And I know that he had to go through it relatively quickly just due to some of the technical issues. But if you had a chance to read some of the slides, you can see the information on there is quite impactful. So we're going to talk a little bit more just about financial stuff. As I mentioned before, these are just my opinions. It's always good to consult with a banker and an accountant. As I mentioned before, last week, the HHS stimulus, the second round of money, $20 billion. Dr. Montacani had mentioned that they're working on getting this distributed to practices in the Senate. Senator Cassidy's been instrumental in helping us out. There's a website link on there, and actually if you just Google HHS Coronavirus CARES Act Provider Relief Fund, it'll take you to that link anyways as the first link. But in order to qualify for that money, it is my belief, and if you read that link, it states that you have to go to a general distribution portal and log in and complete an attestation. You need 4 things: your gross receipts or sales, as submitted on your federal income tax return, your estimated revenue loss, and it's just an estimation for April and March of 2020 based on the amount of dates of service and claims that you would ordinarily file, not necessarily your gross collections. And then a copy of your most recently filed tax return and your TIN number and Medicare numbers. And then the first round of HHS money, which we all got, just make sure you please attest to that. That literally takes 4 or 5 minutes. That link is up here above. And since we've talked about this before, I'm just going to move on to some other things. ASIPP has distributed this procedure suite and ambulatory surgery center checklist. It's an Excel spreadsheet where there's yes or no answers and just a quick question survey to go through. There's a couple reasons to do this. One, it may jog your memory of things that you need. I mean, it gets really granular with details like making sure your RFA machine works, your C-arm works, making sure, you practice social distancing and have a protocol for hand washing, et cetera. But the other advantage is, if your Department of Health comes to you or checks on you, it is evidence that you made a good faith effort to mitigate risks. And I think that's always good to help you out in the long run. The PPP forgivability of the loan, I think that's very important. So I want to talk about that now. Okay, because there are some things that we're all going to need to do. I know a lot of people got this loan. A lot of people that have their own practices have, or if they work in a group practice, they've gotten it. And you know that basically it covers an 8-week period from the date the loan originates. And it covers payroll costs, and it covers any payment of interest on a mortgage, not including any prepayment or payment of principal on that mortgage obligation that was occurred before February 15th, 2020. Any payment of rent under a lease agreement in force before February 15th of 2020, and any utility payment, including payment for distribution of electricity, water, telephone, internet, etc., that were in existence prior to February 15th. And it's important to try to save that documentation, because documentation is going to be key when you start to to apply for that. So what actually is a payroll cost? Well, it's salary, wage, commission, or similar compensation for a partnership. Recent guidance from the SBA explains that payroll costs include, but are not limited only to guaranteed payments to a partner, but also the partner share of income of the partnership. So those amounts have a cap of $100,000, and I know per year, and I know obviously several physicians may make more than that, but at least you can recoup that much on a pro rata basis for the 2-month period. Payments of cash or tips, which doesn't really apply to us, but you also get payment for vacation, paternal, family, medical, or sick leave. Payment required for provisions of group health care benefits, including insurance premiums. So it's important for you to save those receipts as well. Payment for retirement benefit and state and local taxes assessed on the compensations of your payroll. So what's not a payroll tax? Well, there are a lot of things here that don't really apply to us, but you can see in excess of $100,000, and then very specific taxes that are withheld under certain chapters. Honestly, a lot of those don't exactly qualify or pertain to the interventional pain physician, but I put those on there just so you know what's up there. So just some stats about the PPP loans. You know, the interest rate is very generous, 1%. So listen, even if it's not forgivable or portions of it are not forgivable, you still got money with quite a cheap rate, and paying it back plus 1% is not a terrible thing, considering that it does provide you some float during this difficult time. You have to contact your lender to pay back your loan. So you don't contact the SBA, but the actual lending authority or bank that actually gave you the loan. Make sure to keep good records. I know some physicians and some practices that are maintaining a separate bank account for their PPP stuff. I mean, it's fine to do that. Even if you haven't done that, just make sure you maintain good records. Make sure you're really good about documenting and maintaining all of your receipts for stuff that you perceive to be forgivable. And one thing that's good is to engage help with your payroll provider. So, I mean, if you do your own payroll, that's fine. Just make sure you keep all your information. But if you outsource it to like Paychex or ADP, they can actually help provide you reports that you can provide for the PPP. So, for example, I use Paychex in my clinic, and I contacted them, and they said, great, just tell us the bank and who you worked with and all that, and your loan amount and your date of loan funding, and we'll maintain reports for you that you can just then turn over to your bank. And that's all I have regarding the business stuff, and I'll now turn it over to Debbie, who's going to discuss reaching out through social media in the Corona era.
Thanks, Amal. It's so helpful, all the information that you gave us. All right, so thanks, guys. This talk is about social media, and it's not so much that I am such a huge advocate or proponent of social media. It's more that I think that now is the time to take advantage of it so that we can build our practices, bring the patients to us, and also find out more information. Now, we're lucky because we're part of ASIPP, and these webinars have provided most of the information that we need, but still it's helpful to be plugged in to get some of this information as well. So the first thing I would say is, to think about a social media right for you, and if so, maybe which websites, which applications, what exactly are you trying to do? So especially now when there's so many changes, there's a lot of instability. We don't know exactly what will happen after all of this sort of passes or over the next few months. Whether or not you own your practice, you're an employee in a hospital, or you're an employee for a larger practice, you may still want to have your own website or your own presence to attract patients to you. So if you don't have your own website, now might be a good time to create one. It doesn't have to be fancy. A lot of websites I've seen that are very effective just have some pictures. People tend to respond a little bit better to pictures, just some basic information, almost like a business card for people to be able to contact you. And especially now when most people are at home, it might be a good time to hire a college student or somebody to just create it for you if you're not as savvy about it yourself. Some of the things that can attract people to your website, there are keyword searches or search engine strategies people will talk about, search engine optimization. But one of the simple things is, you could include your information, but also let's say that you see an article that you think is very interesting to you, maybe from the New York Times or from something that already attracts a lot of people. You could write a counterpoint to it, use a lot of the same words, and sometimes when people search for that article, they will also be directed to your website. It'll come up in the search because there's so many words and other things that are there in common. You can also think about what types of patients are you trying to attract. So social media, I find, is really useful if you're trying to attract younger patients. When I first started my practice, when I left the VA, I had been pretty active on social media, like with YouTube, Facebook, all kinds of things to attract patients. And, we brought in a lot of millennials. We brought in a lot of younger patients that were already pretty savvy about their health. It was nice because they were motivated and they got better. But then after a while, I realized, well, maybe they'll have procedures, maybe they won't. Maybe they'll follow up, maybe they won't. And so then I realized, well, I really need to kind of balance this out, maybe have some older patients too with, other types of health conditions as well. So social media by itself may not be the best thing, but you want to think about it in terms of how can I grow my practice and who am I trying to bring into the practice. Another thing to consider is during this time, can you grow your practice while you're closed? So I've been noticing some folks are actually trying to advertise their telehealth practice so that they can bring in new patients that way. I would say you want to be careful because some states, it might depend, and with your malpractice carrier, doing telehealth visits for follow-up visits might be one thing. It may not be as effective. You may not have coverage to bring new patients in if you can't do a physical exam. It's not that easy to review prior records and stuff, but it's something to think about. Maybe you could, if you are allowed or so inclined, maybe you could grow the number of patients that you have, and then when you do open, bring them in for the face-to-face visits. There are different types of things that you could do on social media. I mean, one thing I saw from another pain management specialist that I thought was effective was a video journal. So he had been volunteering in New York and kind of doing a video diary, very informal. This isn't professionally edited stuff, but I think stuff that he recorded on his phone, kind of talking about it and then posting it for his patients or their colleagues. And I think that also helps to kind of increase awareness about people. So if patients do look for him, they know a little bit more about his story and they can find him more easily. If you were to do something like that, I would say generally people do respond to pictures and videos better. The shorter, the better, usually. It doesn't have to be fancy. It just has to be more concise and kind of directed towards the right person. For educational videos and things like that, YouTube is usually really good. Facebook, so I use Facebook a lot, but I don't use it so much for patients. I use it more for personal purposes because it gets tricky if you have both on the same sort of page. What would happen is if I posted kind of personal images, then it was a little bit weird if I had patients also responding. On the other hand, I couldn't say much that was too technical about the practice because then it would sort of confuse the people that I know, like from high school, who have nothing to do with pain management or anything. So you want to think about that. Sometimes people will separate out their Facebook page into a professional page. And I've seen that a lot, but there's some issues with that as well, because if you're posting things pretty regularly when you first start because you're excited about it, you may gain a following, but then if you just sort of disappear and don't do the posts anymore because, it's time consuming to do all of that, then you may lose some of your audience. So things to think about. Twitter is another one, obviously a favorite of our president's. TikTok, if you want to get to the younger generation, that's useful. Those are very short, 90-second or less videos that can be posted. And then WhatsApp, I find that this is more common among people who are a little bit older, especially sort of, as a network. It's not really a social media app, but just for text messaging people from all over the place. So a lot of things can be forwarded much more easily. So these are things just to look into if you're interested. For my purposes, I kind of looked at it. I wrote this book, Coronavirus Made Simple. It's not, it links to the CDC and to the coronavirus.gov site, but it's an ebook. I wrote it mostly for my patients. At first, I was writing it for them because with everything happening in New York, they were just extremely stressed out. There was a lot of confusion, and it's more a health literacy book. So even though I published it March 22nd, all of the stuff still holds true because it's more the background about why is it hard to develop antivirals? Why would something like this maybe not be caught right away? But at least for my purposes with the book, to educate my patients, to give people a little bit more health literacy was very helpful. But if there are things during this time when it's a little quieter that you think might help you on the other side of this, now is the time to kind of invest in that. In terms of other things, we were talking about growing the practice, but also just establishing a network. We find that social media chat rooms are also very helpful, especially on Facebook. So, we are part of a network with ASIPP, but if you think about some of these, what it is like people pull you into a private group, and you can find out a lot about political advocacy, any legal information. I've seen some videos from employment lawyers that are very interesting. You can hear more about like the nitty-gritty of coronavirus and how it's presenting and what they're dealing with in the hospitals. And you can also find out like what other people are doing. So not just pain management specialists, but what are other doctors that are in these kinds of settings doing to open up. So it can be very helpful if you're trying to figure out what's the standard of care at this time. I'll just give you some examples. So this was an article that was, I took out the names of the people who posted these things in the chat rooms just for their own privacy, but I was surprised, like some of these things about public perception, for example, these telehealth visits that we're doing, which is not really our choice, but we're trying to help the patients, right, during this difficult time. NPR was criticizing doctors basically by saying, well, we used to make phone calls for free, but now we're kind of capitalizing on this. So, sometimes seeing this, of course, it can, it can be inflammatory at times, but at the same time, you can see what is the public seeing while we're kind of working on these other issues. Insurance information, so people can post their own things that, hey, all my claims are being rejected, and then kind of decide, like, what can we do about that? Jobs, what's happening at these different universities. So sometimes you'll see articles that might catch one person's eye, but other people don't see necessarily, and then you can get more information that way. Malpractice, here, people getting ready to kind of potentially sue the hospital for some of the things they're doing to try to combat the coronavirus right now by pulling people in from other areas. And then, of course, like different things. I mean, this was more not for the offer, but Verizon, for example, said they wanted to give discounts to first responders, but doctors were excluded from that. So just some things that are interesting to see. When we're talking about PPE, how do we get it? Well, sometimes people will post in some of these groups like, hey, I don't know how to get it, and then you'll get other people respond with where they can find some of the stuff. So ASIPP has always been helpful with this, but still it might be helpful to be in some of these chat rooms to kind of know that as well. Just one thing to keep in mind, the World Health Organization said that we also have an infodemic, not just a pandemic at this time, meaning that we have a lot of misinformation and other stuff going around. Sometimes there's too much information to sort through, but hopefully at least, as physicians and working in this area, we can sort through that a little bit more easily. So thank you so much. I think I caught us back up on time. So, all right, thanks.
Thank you, Devi. That was great. It is so great to have you. And informatic that is a really good word. Probably World Health Organization is one of them who is sending all the false information, or some of it anyhow. Our next speaker is Sunny Jha. He's started as a resident fellow board member. Now he is a member of on CPT committee, and then he also AMA CPT committee, and then he's the alternate delegate for AMA. He is young, dynamic, and he wants to tell us how we can help young physicians or they can be helped. Sunny?
Thank you so much, Dr. Manchakanti. I'm going to talk to you guys a little bit today on the quality and value of ASIPP and how it's kind of changed my life and how it will change yours as well. So I think this picture really shows a lot. This is a photo from us a few months ago in DEC, or about the 2019 lobby day we had, where you have our leaders of ASIPP and a lot of the private practice folks and our members on the top, and below you have some of the very prominent politicians that came and spoke to us and gave their comments unscripted. It's really a phenomenal experience, and I'll talk a little bit about that later. But I think these photos, you keep these photos in mind, and they'll kind of personify why I value this organization so much. So we are the premier pain organization defending you in DC and around the country. We've had decades of relationships with influential congressional members, and that's critical in order to ensure that we protect and preserve our practice for our patients and our profession. We've been working hard on pre-authorization, reducing the onerous burden. You'll find that term used a lot today, onerous burden, that pre-authorization provides to all of us and our patients here. We recently, one of our former board members, Vanilla Singh, just published the Best Practices in Pain Management Guide by HHS. And that was critical to helping legitimize and more or less give the stamp of approval from HHS on the strategies that we all employ to help treat and prevent folks from falling into the opiate epidemic trap. We're also working hard with attorney generals across the country to help stop and inform medical boards on best practices in pain management and making sure the right folks are the ones talking to physicians and making sure that our patients are secure and protected. We also have a long history of defending and improving your reimbursement rates through SGR, through all kinds of direct advocacy through Medicare and through the CPT and through the RUC. MIPS, EHRs, and as Dr. Mangiaconti likes to call it, meaningless use, on the implementation of quote-unquote quality metrics and EHRs, which are supposed to be helping us become more efficient and make us more efficient and not necessarily be burdensome. I think the Burnout Survey data was critical, and it demonstrated that the revenue collections and EHRs were two of the main contributing factors to physician burnout, especially in outpatient pain medicine. So we talked a little bit about this before. Dr. Mangiaconti, Dr. Soin mentioned much about a lot of this stuff here, so I'll continue moving forward to the next slide. So other critical legislative accomplishments that our phenomenal team here can take pretty significant credit for, and that's the National Prescription Monitoring Database. We were the first organization to promote this and to get this passed. So the law has actually been in the land for a long time, and actually all 50 states now have prescription monitoring databases. So that all came from ASIPP. We were also critical in using our relationships that we've had for a long time to advocate for the repeal of the SGR as well. We have two former congressional members, Senator Tim Hutchinson and Congressman, his name is mistaking me right now. Yeah, exactly. Thank you, Dr. Mangiaconti. Who have been phenomenally helping out with our organization, ensuring that we maintain a phenomenal presence in the Capitol. We're also one of the main pain societies who routinely hold legislative fly-ins. I think this is critical. I've heard from physicians for years throughout my entire time in healthcare about how medicine is getting so screwed up, and people complain. And I love when I hear physicians complain, because that makes me feel like we have hope in making our healthcare better. But this is one way that you can really take your complaints and make sure it's actually heard by those who can make a difference. We get really great face time with some of the most premier, most influential congressional members to ensure that our priorities are made a priority interest. So I really strongly encourage all of you to attend. And I've been to many DC fly-ins from many different organizations, and ASIPP by far has the best ones. And no one else gets the kind of high-profile speakers that we get, and the amount of time we get with them. And you're about to see that later with Senator Bill Cassidy, one of the most prominent senators in the Congress right now, and he's a close friend with the organization. So it makes things a lot easier for us to get done when we say we represent ASIPP and make a phone call and say these are some of the issues where our organization, our members are facing. Can you please help us out? And we also present them with a lot of solutions. For example, with the prescription monitoring database, we said we needed to help ensure that there's no prescription shopping by patients. Here's one way that we think might work. And boom, we have prescription monitoring. We also have the ASIPP Political Action Committee, which is also critical. It helps us support candidates that are in favor of the things that we are trying to promote for our patients and our practices. So I encourage all of you to, again, donate to the PAC and stay consistent with your donations. We also have a lot of behind-the-scenes activity that lot of our members probably don't really know about, especially if you're not really engaged in organized medicine or just the overall way of business of medicine. But the CAC membership is also critical. This enables us to make sure that we are at the seat when valuable decisions are being made on how to allocate Medicare resources, and making sure that when local coverage determinations are being made, that our procedures are being appropriately compensated for. We also, as Dr. Machikati mentioned, I am a member of our AMA delegation, and I must say that we are probably one of the most influential subspecialty societies in the House of Medicine. We are sitting at the table with all the big organizations, American College of Physicians, ASA, all these ginormous organizations, and they basically look to us to lead a lot of discussions. Our AMA delegation is very, very influential. We have the current California Medical Association president-elect, Lee Snook, who's our delegate, and we're actually, through phenomenal advocacy work by you guys and through engagement, we're actually going to be getting another seat in the American Medical Association House of Medicine, House of Delegates. So we're actually going to be the largest pain society that's being represented in the AMA House, which is phenomenal work. And it's just and we want to thank you guys for maintaining concurrent membership in both the AMA and ASIPP. And please continue to do so, because we can also make further impacts on our reimbursement rates as well through our activities on the RUC and the CPT committee to make sure all the brand new procedures and all that stuff can be appropriately reimbursed as they come about. And we're even doing stuff locally for you guys. We have state societies across most of our states here that are also providing leadership opportunities, conferences, CME activities, meetings, and they're phenomenal, large conferences. I think New York, California, Ohio have done, Florida have done some amazing conferences, and great opportunities for you to stay engaged at your local level. There's also localized advocacy. A lot of the issues that we're facing, is particularly in the time of COVID, how different states are going to have different requirements for how you can reopen. So our state societies have been critical in disseminating that state-specific information out to you guys as members. We also provide a high-quality CME through these organizations, as well as ASIPP itself, at our meetings, through webinars such as this, also board certification through the American Board of Interventional Pain Physicians. Again, providing a certificate of approval saying that you are indeed a legitimate pain physician. Also competency-specific certificates on different procedures as they come out. And we've also provided practice expense guidelines and so forth. I think I'd be remiss without mentioning our pain physician journal, which is one of the highest impact journals in medicine, particularly in pain medicine. So it's an open source journal. Everyone has access to it. We just publish every 6 times a year, and we are going to be having a special COVID issue coming out in the next month or so. So please submit any articles that you have regarding COVID, if you're continuing forward any complications, anything related to COVID, and we'll consider it for publication. We also have the pain medicine case reports, which is also incredibly popular, enables especially some of our younger physicians who are hoping to really establish their name to get their case reports out there. Very easy to submit. Again, open source, open journal publication here as well, and phenomenal work there. We also offer group purchasing organizations to help with you guys with your purchasing plans. Revenue cycle management, as noted, we have a 3% rate through Fedora. Again, this is a problem. This is a serious issue with in-house revenue cycle management being a tremendous source of burnout. So this could be another way for you to help make it easier for you to practice. We also have liability insurance deals worked out with NorCal Mutual, 20-25% savings at bare minimum, and plus an additional discount if you're ABIPP certified. And we want to say we were sorry that we couldn't see you guys in Dallas last month for our annual meeting. To our residents and fellow members and our younger physician members, we do have phenomenal opportunities, and we are acutely aware of all the issues facing, particularly our young physicians who are looking for jobs or just started jobs and suddenly find that their job security is not very secure. So we're going to be providing specific tracks for all of our younger physicians and our RFS members as well. We have abstracts and poster sessions, podium presentations, And basically, our speakers are phenomenal. You're learning from the best in pain medicine. Our keynote speakers are phenomenal as well. We're going to be having Kevin MD, Kevin Foe from Kevin MD. He'll be our keynote, and while providing me networking opportunities. And we'll actually be even honoring some of our pain physicians through our award ceremony to make sure that your hard work is being rewarded appropriately. And so here's our schedule for our next few meetings. Dallas, New Orleans, Las Vegas, all great cities, and we look forward to seeing you guys there. Thank you.
Thank you, Sunny. That is a great presentation. Some of them were questioning that I already got messages saying that we are the ones who obtained interventional pain management designation and also the definition of interventional techniques. I think you did mention it, but you went through fast. You finished on time. That's great. So now we go to about time management. We all have issues with time management, especially me. We have had a lot of downtime for some, but it is not all the time. So I have been really busy, and I've been told that I was working twice than usual. I don't know how that can happen. I was always working. We all need some tips on time management. So we have Shelley Baer. She just is across our office in Paducah. She's a psychologist. She also has worked she also did significant charitable work. She runs the Emerald Therapy Center, and she does addiction counseling. And I know it is not of interest for you to refer the patients to her, but in Paducah, we refer patients to their facility for psychology. So here is Sherry. Sherry?
Thank you very much, Dr. Mangiacane. I appreciate that introduction. Yeah, so I'm going to speak about time management. It's very important because we don't get it back. All of us have 1,400 minutes in one day. And after that time is gone, it's gone. It's not like we can replenish time like we can other areas of our life. So how do we manage our time as well as the other areas of our life? Well, 40% of adults say they'd like to spend more time with their family. It makes perfect sense, doesn't it? So how do we really manage time effectively? So basically, time management is just having a conscious control on the time spent on the tasks that make us more productive, more efficient, and more effective. So it's controlling and managing that time. So we're going to basically just identify clear goals and have those down. So what we like to do at our organization is we really go by our 4 areas of wellness. And we set our goals based on our emotional goals, our physical goals, our financial goals, and our spiritual goals. And then as an organization, you should have these posted, what your goals are, so every department and every person can kind of see what you're working towards as a team. So you've got your personal goals and then your organizational goals. We're fortunate now to have a lot of great resources to help us really manage our time. We love any electronic type of app that we can use. It's a lot better than the old Post-it sticky notes that you might lose or the legal pad. Although those were effective, now we have so many more tools that you can walk around with to use those. Plus, it allows you to stay on track and really avoid distractions. Make certain that they all sync together. One of the things that we like to do is when we're working on grants or research projects or working on some sort of a treatment plan for a patient, to be able to put down that thought quickly and then to have it with you. It's just so valuable. So it can really save you a lot of time. I want to talk about time blocking or time boxing. A lot of entrepreneurs use this method. The military uses it. And I think Elon Musk actually makes it pretty famous. And basically, you designate time for projects and research, so you're not constantly interrupted. So one of the things that's hard for healthcare professionals is trying to manage the business side along with the patient care side and the research side, along with the social media. So everyone's wearing so many different hats. And having to block time to complete one certain aspect is really, really important. And then the other thing about that is folks who have some traits of ADD or ADHD really benefit from time blocking as well. Most of us know that whenever we get to our organization, our practice, that it can be a day of distractions and we really don't get the things completed that we really wanted to. So there's an approach called the heads down, hands down approach. And basically, you shut down your emails, those notifications, everything that really distracts you from that task at hand. And I like to look at people who are incredibly successful and happy and healthy and ask them, how do you do that? Tell me what's working so we can implement it with our patients and with our practice as well. So we love to say we're going to block off this time unless someone is bleeding or needs us. Let us get this done. It's very effective, and it kind of puts an end to the myth where multitasking was really the end all. Actually, what we know, a study by the University of Michigan found that people who multitask decrease their productivity by 20 to 40%, and they're less efficient than those who are working on one project at a time. So, spinning a lot of plates may make us very, very busy, but it doesn't necessarily make us more productive. So, time blocking is a great, great way. We want to get organized and work smarter, not harder and not longer. All of you are working a tremendous amount. The last thing you need is more work or something that takes up more of your time. The average American spends 1 year of their life looking for misplaced or lost items at home or the office. Think about that. A year of your life totally gone for looking for things if you're the average American. So get organized with your subfolders on your computers and your email. And think about your agency when something important is out of place, the stress and anxiety it can really cause. So time management also fits in with not becoming so perfectionistic and having that mindset that it really costs you more time. What that means is, while a medical procedure has to be seamless, we as human beings do not. So get rid of that perfectionistic mindset that costs hours and hours of time when you're only really tweaking a few mundane details. It also will cost you a lot of revenue. So there again, when we work with CEOs of corporations and lots of different very successful people, we find that they know how to get the task done at hand. And, I use the example that a lot of times they'll literally move something out of the way and sit down and do it there so that the stars aren't in alignment. So one of the things we also find in working with lots of various people is we all have excuses about when I get this done, when my car is washed, when my bills are paid, when my lawn is like this, when my agency is running like it should be, then I'm going to do this. And what we realize is that's really anxiety related to procrastination. So that procrastination is just a way to say, I'm nervous and I'm anxious about this task. And it eats up more of your time because you're kind of doing everything but that important task at hand. We love working with organizations and helping them make their system very healthy. What that means is we do a lot of things with pre-employment screening, where we help people hire the best talent, retain the best talent, and place them with a team where they can really be retained. So when you're looking at hiring people, you may not have someone with a diagnosis, but they could have a lot of strong traits of something like ADD or ADHD. And those folks are great in a fast-paced atmosphere that changes often. And they can really focus very intensely, but not for long periods of time. So when you're building your team that's going to save you time, think about those traits. And I'm going to quote Dr. Mangiacani here, and he says that folks with OCD traits are often make the best employees. So they do a great job at very tedious, technical tasks and projects where there's a great need for documentation and review. They're great coordinators, and they can really manage a lot of the spokes of the wheel. So think about your work environment. How healthy is it? So think about what you can do to improve that environment, whether it's you and one other partner or it's a large organization. And then also just really be aware that there's a lot of things that you're going to be able to do to really process what's happened to you that particular day. So what we know is there is a time to really debrief. Schedule that in. Make certain that you plan to debrief about the things that you've witnessed that day, the emotional energy that has taken, the emotions that you've experienced by those events, and really help compartmentalize so you can function well at work and in your personal life. So it's helping you avoiding burnout. I'm going to wrap up with just some very practical tools. And remember, these are all at your fingertips. You're going to design your mindful workspace. You're going to learn some CBT techniques to really debrief. You're going to practice pre-employment screenings and implement those into your organization. So you've got supportive staff around you and very intentional people working with you. You're going to have electronic apps on your phone that save you all those long lists that don't get lost. And they're all really important because remember, time is the only thing that we don't get back. We only have a limited amount of it, so we want to make the most of it. So thank you all very much for that. Dr. Mangiacani?
Thank you, Shelley. That was great. Shelley works with us, with our organization or our practice with anger management, stress management, and employee screening, and she does a whole lot. So we can take some of her advice. Thank you, Shelley. Is Senator here yet? Okay, so it looks like Senator is just going to dial in a few seconds. We will go ahead and talk about other things. I can we can talk other things. So there is a question from about 99213, 99214 telemedicine with GT modifiers have been paid for March by NGS only at about 60% of the regular fee. What else should I do to get the rest of the money? I would suggest that you use new telephone codes which became retroactive, and you will get paid, refile with those codes, and you will get paid at a higher level. So that was one question. The second question is, we are in New York. Oh, this somebody else. Did you answer that, Devi? Okay.
I think someone else answered it, but I agree. We're not doing any procedures in the city either. Okay.
There is a question on Illinois. Please comment on urgent versus elective office-based cases. Does anybody wants to answer? I can answer that. So Illinois is one of the very difficult states, as we call it, People's Republic of Illinois. And I have an office in Illinois. It is very difficult to get any information and anything to do. Right now they are saying that any elective procedures you have to, which starting May 11th, you can start doing them, but you have to have COVID testing on all of them. It is virus testing, not the antibody testing. And within 74 hours, and after that, they had to be quarantined if they had tested before until the procedure. So we are trying to change that rule, but we don't have any luck yet. So we are waiting on that. We should hear any time. I will let you know. The next question is the HHS money going to be taxable as taxable income? Amol?
Great question. And to be honest, the exact answer for that is not exactly clear at the moment. The conventional wisdom is that it would be listed as taxable income, but our hope and the hope of many involved in the process is that it will not be. So I think we'll be able to provide you further update and guidance once we hear a formal declaration on what will happen with the HHS stimulus money in terms of it being taxable or not. There is a tremendous political pressure for it to be non-taxable income, but because that hasn't formally been announced, it's going to be difficult for us to officially announce that.
This is Harold. I have a little update to that. Yesterday, the SBA as well as the Treasury Department made a clarification on not this portion, but on the Paycheck Protection Act, that they will not consider it taxable income. However, you cannot deduct any payroll expenses or expenses that you paid with that money. There are going to be there's some challenges already to that ruling. The Treasury Department said that they were going to probably change some of these things and be additional clarifications, including the portion of the HHS thing. So, Amol, you are correct. They haven't addressed that specifically, but the PPP they have, but expect there to be a challenge. So the part of the CARES Act stated that none of these loan forgivenesses or things are meant to be taxable income. So that helps.
Okay, I think, is he here? No. Okay, so the next question is, you mentioned that we should be getting 115% of the fees. NGS, Medicare has not done that. How can I ask for it? I don't believe that any of us mentioned 115%. It is 100%, as if you have seen the patient in the office. So that is how the new codes are too. So you should be able to get 100%, not 115%. Okay, thank you for that question. The next one is, some states have legislation against COVID-related lawsuits. Any idea if rest of the states will follow? Shalini, can you answer that?
Sure. I don't know if there are any COVID-related lawsuits at this point, but I can imagine that there may be going forward, particularly as we start opening up procedures again. So, you know, the best advice is to check with your insurance carrier and your insurance coverage to see what they will allow, what they don't allow in terms of for you to open up or how aggressively they ask you to open up. That's the best advice I can give at this point.
I can add one.
Well, go ahead, baby. Okay, go for it.
So I was just going to add, so I've been talking to our malpractice carrier. You have to ask the person directly, like your contact at your carrier, but at least in New York, there is immunity from liability for people treating COVID-19. So, for example, if you're treating a COVID patient, let's say you were volunteering or something else, they can still sue you, but ultimately nothing should come of it because you have immunity. But that's for treating patients who have COVID-19. That's not for most of us who are treating patients who have other issues unrelated to COVID-19 during this time.
Okay, thank you, Devi. Now, Senator is here. We are very pleased to have him. Senator Cassidy is also a physician, a gastroenterologist, and he has been practicing in Louisiana for some time. His wife is a general surgeon. He is very well known to our community. He has been at ASIPP meetings on multiple occasions. He is one of the best senators and reachable and knowledgeable. He's the only one who stopped when they were trying to block the nomination and answered the people. Everybody was afraid and leaving. He actually contributed to Mary Landrieu, and then he defeated her in the election for Senate. He has done a lot of social work, and he created a healthcare facility at Kmart building during Hurricane Katrina. He has done a lot for us. First, we thought, if you remember, I told you that $100 billion was just going to go to the hospitals, but now him, Mitch McConnell, and several other senators together have diverted some of that to physicians. We are receiving already, I told you earlier that the second one checks will be coming tomorrow, but looks like some of the folks have already gotten. They sent me emails. Now, we are still concerned about what else is going on. As I said, there is $50 billion more in the first one and $75 billion from the second one. Senator is going to address that further. They also stopped the advance payment program for Medicare. We were able to get loans for 3 months. Our issue is related to several things. All the help is for 2 months, 2.5 months, but our problem is going to linger on for about 6 months or longer. We are going to face a significant blow. So, Senator, floor is yours.
Hey, Lex, thank you for having me. And I have one of my staff on, Jeff Lucas, and there might be some questions I might defer to Jeff if I don't know if he's in the green room or not. But thank you all for seeing patience. Thank you all for hanging in there. Everybody recognizes that we have to have a return of medical practices as kind of the first businesses that reopen when we reopen our economy, and to most effectively reopen our economy. And the pent-up demand that is there is obviously, we just have people in pain who need to have their pain addressed as one example of issues that have to be addressed. So you've mentioned that I've been on the call for about 10 minutes just listening to you speak. So you all are familiar with both the payroll protection plan. At some point that will run out of money. The question is whether or not we add more to it. I think we're up in session now to kind of assess to what degree has it been effective, how much more would we need if more is needed. But if you're going to file and you haven't filed, I just recommend doing it as soon as possible because at some point it will once more run out of money. The Medicare advance payment system, or payments, that has been a lifeline to some, but the interest rate has been perceived as being too high. We understand that. The question is, it does come out of the Medicare trust fund, and so how do we make sure that money is there, but that the trust fund, which is going bankrupt, is held harmless? And that's the needle being threaded now. You spoke about the HHS stimulus money. Yes, indeed. We did work to make sure that included individual practices as well as ASCs, and also to make sure that it was not based only on the Medicare business that folks had done, but rather on their total book of business, and that is how it is currently being implemented. So there is a lot of effort. Now the question is, when do we reopen? Again, I heard that Illinois is reopening, but for all practical purposes, it's going to be hard to meet those guidelines, particularly if it's going to require you to have testing on everybody when testing is not yet widely available. So my own state of Louisiana is beginning a reopening process, and not quite as onerous as it sounds like it is in Illinois, but I know Paul Hubbell's on it, so he may have more insights into that. On a federal level, there is interest in the Republican Party to do something about liability reform. I heard someone say they didn't know of people yet being sued, but I've seen advertisements. If you feel like you've gotten COVID from fill in the blank, call this number, and you can file from home, so you don't need to leave your home in order to file a case. So there's going to be some enterprising attorney out there. Indeed, one of the senators spoke, a lawyer spoke, that they are calling this the next tobacco, which, if that doesn't mean anything to you, think of the big settlements that came from big tobacco companies. can they in some way have the same sort of reward for the trial attorneys as they all receive from the big tobacco settlements. So that is going to be on the federal agenda. Two things about that. Torts have by our Constitution been a so-called 10th Amendment issue. It is one of those issues that is state-based. And so and then secondly, Democrats absolutely oppose. Let's face it, the trial bar is a huge contributor to the Democratic Party, so they're always going to be loath to take on a special interest of theirs. So whatever legislation is offered, and there will be legislation offered, it'll have to be narrowly crafted to address the kind of federal-state tension to make sure that we're consistent with our Constitution. But at the same time, if there's a federal angle, attempt to address that. I do think it's important to address it. You can do everything right, but somebody goes out and contracts COVID from another setting, and you're the person that gets blamed. Well, that's not very smart. It may be smart for the trial attorney, but it's not smart in terms of encouraging businesses to reopen. But when they reopen, I do think there'll be some sort of OSHA guidelines. How do you maintain social distancing between employees, et cetera? How do we go to next steps? I'll touch briefly on that, then I'll take questions, if you will. Going to next steps, I truly think that's where we as physicians can really add to the discussion. If you look at the prevalence of disease, it is not equally prevalent everywhere in our country. It's certain hotspots. But even if you look within a hotspot, there are hotspots within hotspots, and then within those hotspots, there are buildings that are hotspots. So there is a way to use our information systems to begin to focus on the areas, both that are more likely to have infected people within them, therefore they need containment strategies, particularly for those buildings or those census tracts. But there's also populations which are greater risk. Think about an apartment complex, which is effectively assisted living, and everybody there is over age 65 or 75 with a higher prevalence of comorbidities. If infection does enter, they are particularly at risk for death. So I think that we need to begin to employ our information systems so that we, as we screen, are able to do better containment and better avoidance of infection. I personally have advocated that we have what I call an exposure registry so that nurse's aide who is tested, we know that she's antibody positive. She's been previously exposed. She is now clear. She does not need to have repeated RNA testing. By the way, this presumes that antibodies will be deemed to be protective, but I think that's going to be the case. And so if you have people in your workforce who we know are immune, then you may put them in a place which is more public facing. And if you have people that you in your workforce that are not immune or with comorbidities that place them at higher risk, you would put them in settings where they had less exposure to the public. Similarly, if you had a patient whom you knew had been previously exposed and recovered, you would use different precautions, maybe a different room, than you would for someone whose status is unknown or who is still susceptible to infection. So I'll pause there, take any questions. But Lax, thank you for having me, and thank you guys for still, working, keeping your practices open, trying to do it right. We need you to do so. And again, I'll take whatever question you have. Thank
you, Senator. I still have another question. I just read that this program where they want to pay every American $2,000 per month, guaranteed. I don't know how long until we go broke or something happens. We are already broke though. But so how is that going to help the employment or unemployment? That is going to actually hurt people because everybody gets it. Then what is the need for working? Of course, they can't make on $2,000, but if they can get also unemployment with that, then it will be fine. So employers are not protected at all with what they are doing. I really, really appreciate what administration has done, and this is the most responsive Senate, and you have been one of our champions. What I think, if this ever passes the Senate, if it comes to you, then the $2,000 should be credited to the employer towards the employee cost. That might help.
Well, a couple things. Yeah, a couple things. There was the one piece of legislation, the so-called stimulus checks, where individuals got $1,200, couples could get $2,400 up to a certain income level. And the idea was is that right when the infection broke and people were shutting things down, folks had bills due, et cetera. It may have been, but there's there's nothing that's been passed that would make these payments permanent or monthly. Andrew Yang spoke about that, but that is certainly not what's currently on the table. Now, as regards the unemployment checks, you're right. Many people are earning more not working than they would working if they were unemployed. Very practical problem. In my state, I assume it's true in every state, there is a piece of paperwork you can file with your unemployment insurance system that says that if you offered somebody a job to return to their place of work and they refused, well, then they no longer qualify for unemployment. I asked a guy who did this, well, I mean, did burn your bridges with the employee? He goes, oh, no, they got to eat. And they just come back to the job, which they know. You know, it's just the rules of the game. They know it. They're just gaming the rules for the moment. So I did speak to a physician at East Jefferson Hospital, and she wanted to reopen, but she couldn't get her employees back. So I gave this piece of advice to her. Now, as regards going forward, the longer we're in this lockdown, the worse it is. Republicans recognized that $600 a week extra, in addition to unemployment and the regular unemployment, was going to encourage people not to work. We're going to have record high unemployment, but no doubt it's partly due to some people deciding not to work because they're making more while being unemployed. I don't want to be partisan. I'm just telling you how the politics are. Democrats are going to not only oppose changing the $600 a week, but they want to extend it to the end of the year. That legislation is going to be filed. So I'm making great pains to show I'm not being partisan. I'm just telling you what the facts are. And we can imagine why that is. But that really would continue to encourage people not to work. And I think that would be devastating to our economy. So I think we need to figure out how to reopen the economy, use the data, hopefully not need another stimulus check because we do reopen more quickly. It is my suspicion that once the $600 a week extra payments run out, a lot of people will return to work and we won't have the same problem.
Thank you. But there is something Nancy Pelosi was talking about, giving everybody a $2,000 check. Maybe that is the extension of 600 week going to 2,000 a month. But that is in the House. It may never make it to you. But we can't say that you are very partisan because you were a Democrat before, weren't you? So there is a question here. That is a comment. They're agreeing with you. And then one of our members want to know about the issue related to the telephone only issues, and you have helped us on that. Initially, they approved our regular codes, and then they stopped after a month, and then again, they approved with higher payments for telephone codes. So we are requesting them to extend up to August 6th because it is expiring on June 6th. By the way, they made it retroactive to March 1st. So is there any possibility to improve these telehealth codes into the future, including audio only, for a long period of time, especially considering that what is going on, and then some people are predicting that we may have recurrence of this, and then we will be having small pockets of recurrence, so many things. So we can still continue to function in future without a lockdown. So is that possible, and what is your opinion on that? Thank you.
I think that'll be one of the things analyzed. What has been the effectiveness of it? What is the cost basis, if you will, of a telehealth or an audio health visit? Right now, it makes sense to pay a little extra because, frankly, we're trying to subsidize practices. They're trying to set up information. It may be that CMS, I don't know this, Seema Verma is very good. I'm sure she'll look at the cost basis. It might be that it's more efficient to do telehealth, and so maybe it won't be extra, maybe a fraction of, like a 95%. I don't know that. I'm just tossing ideas out there that'll be analyzed. I'm going to be a big advocate that we continue the opportunity for telehealth and potentially audio health going forward. I agree with you. I think it's been successful. It's kind of forced change. I like the fact, frankly, that it allows the use of a smartphone. A lot of elderly people don't have equipment otherwise, but you can certainly use a smartphone to see what their rash is. My wife had chilblains, which turns out that's a COVID symptom. My wife may have had COVID. We didn't even know it. If I thought about it, I would have FaceTimed with my dermatologist, and he would have told us what it was. At the time, we were thinking she just bruised her toe. So I think we're learning that this is a powerful tool. There's going to be a big push to continue to use that tool. I guess what I'm unsure about is the reimbursement rates. But I think telehealth, expanded telehealth, is with us to stay.
Right now, the cost will be the same because they are paying 100% of what it would cost when you see them in person. Effectiveness is 100% because we are able to reach almost every patient. When you go with video and audio, like rural areas where I'm in Paducah, like Louisiana, some of the areas, your reach rate is going to be about 30 to 40%. So it is extremely effective. So hopefully they will do at least extend through August 6th. So maybe Jeff can make a note about it and contact them and support it. So the next question is, on CDC has comment period ending June 15th for opioid crisis, and they did not give fair opportunity for interventional pain. And so we should be able to use this comment period aggressively and include patients and reach the congressional delegates. I remember that you went and spoke to the committee, which was Best Practices Management. Vanilla Singh headed that committee, and she's a member of our ASIPP. She sits on the board at California Society of Interventional Pain Physicians. So you are a strong supporter of that. What would you like to say?
Absolutely, and this is where pain docs are essential. Just speaking to Vanilla, she was so helpful in me understanding. Now I can tell people, which formerly I had not thought about, but now I can tell to lay people, listen, there's I'm going to give you two types of patients. You're whatever you are, a plumber, a lawyer, an Indian chief, and you're going to know exactly what I'm saying. There's the person with chronic pain whose dose never escalates. He is able to function in life, but his dose, again, never changes, and he's been on the same dose for 10 years. And he works, he lives, he's a good parent, etc. And then there's the person who is breaking windows, stealing purses, going to multiple doctors, multiple pharmacies, and who's always seeking more and more medication. Both of those people are technically addicted, but one is quite different than the other. We should treat them differently. Now, you know that. You're wondering why I'm going through that. I can tell you, most of society has to be brought to that understanding. And this is where you guys play a particular role. And Vanilla taught me a lot, and I'm using the information I learned from her and from y'all to try and advance a more sane understanding of how we should go with the opioid prescription problem.
Thank you. The next question is very similar to the other questions, so I will skip that. Okay. Well, I don't think we have any more questions for you. Thank you, Senator, and it is great to see you here, and we'll be talking to you soon. Thank you.
Hey, thank you for having me, Light. Hope everybody's doing well. Thank you all.
Thank you.
Okay, folks, now we are back to our questions here. Okay, I'm lost with this somebody answered this question. So the question is there a specific code for audio only and a different one for video call for telehealth? Now, as far as Medicare is concerned, if you are using video health, you can use the regular codes, that is 99213, 99212, or 99214. For the other ones, you have to use, if you are just using audio only, you can use this code. As you are questioning me, I think you picked this up from our letter or from somewhere like that. It is 99441 is if you spend less than 10 minutes, 99442 if you spend 11 to 20 minutes, and 99443 if you spend more than 20 minutes. So the payment rate is exactly the same as 99214, 213, or 212. It is just the time factor here. There you have to meet 2 of the 3 criteria. As long as you meet the medical necessity criteria, that would be fine. Here it is somewhat different. Okay, next question. As of yesterday, Virginia Governor Northam also requires testing prior to elective procedures. Any help that you could provide would be much appreciated. We have a letter, and we sent you a letter other day that Rick Buenaventura wrote, and we also have risk stratification, etc. I need to look at that. We can share with you the letters we have written to the other states. If you send me an email, I will be happy to share that with you and prepare a letter for you on ASIPP letterhead with your state letterhead. Can hospital consult be performed using, before I go to that, Amol, do you have any comment on that?
Oh, no, I think what you said is appropriate. And actually, I've been reaching out to all of the state presidents of every single state. And what we're going to attempt to do this coming year and the year after, and hopefully long term, is more regional outreach. We'd like to get more grassroots support for things with ASIPP. And at ASIPP, we realize there's a lot of state-to-state variability, not only with COVID, but also just regular interventional pain procedures. So we're hoping that your state SIPP president and your state SIPP leadership team will be more engaged and more involved. And that's something we're going to be working on this year.
Okay. Can hospital consults be performed using HIPAA-compliant telehealth video chat as office-based consults are?
Well, first of all, I would doubt that the hospital would allow you to do an inpatient hospital consult using telehealth. Most hospital bylaws require that you see the patient within 24 hours. That's probably average for most hospitals. Also, that telehealth code that you're using is for office-based, not for hospital.
Hospitals do have an exception. I was talking to Congressman Andy Barr. He told me that he's from Kentucky. Based on a request from Lexington Hospital, he got this exception where if a patient is admitted to the hospital, one of the staff members goes to the inside the room, patient's room, and the physician stays remotely and advises whatever the way we need. So that was to help with PPE, I believe. But that is in effect. You should check with your hospital if that is applicable to them and if they are using that. The next question is to anyone. I can answer that too. I have not received my second HSS check by now. Does that mean that I won't be getting? Not at all. The checks, few people got the checks today. Majority of them are going to get tomorrow, and by Friday, 95% of the checks should be here. If not, it will be next week. But they still have 14 days from the day you completed your application. So, and they are completing applications only on once a week. That may be one of the reasons. Amol, you want to comment on that?
No, I think that's pretty accurate. I have no other comments.
Okay. Then there is one question. What about paying stimulus to the ones that did go to work every day? Senator is not gone, but that is what we have been supporting. If they went to every day, they are getting paid regular salary. But unfortunately, yesterday one of my friends was telling me that his paycheck was only 50% of what it used to be. So I don't know what the nature of the question is. That stimulus money is going, if you want beyond the salary, that is not fair, because it is part of the whole thing, and your employer is going down the drains. And if you are the employer, you should pay your employee physicians what they generated. We are adding that whatever they generated to this year's income, if they are based on the in production, if they are on production basis. So either way, it will be both fair for both of them. Amol, do you have comments on
Yes, I do. So the first round of stimulus money that went out was just a flat 6.1%, and it went out to all areas and all providers. So someone in Wyoming got the same proportion as someone in inner city New York, and that created a huge backlash of news articles and all these questions about fairness. So the second round of money is different, and it is given proportionally based on your income loss due to coronavirus or COVID-19. So the point of the stimulus is actually to stimulate the entities that really suffered due to revenue loss. So the way that formula is calculated is you have to estimate your amount of claims that you processed in March and April of 2020 and submit that through the portal. And the theory behind that is that there will be a different distribution. So if you were in Wyoming and not affected at all and working full-time and received no economic loss due to coronavirus, you don't need to be stimulated, or you don't need a stimulus because you already had your revenue secure and you didn't have much impact. And if you were in a state like New York, where they say, well, you can't do elective procedures, and they basically shut you down, in that case, you are suffering severe economic damages in relation to COVID, so you should get a higher proportion of the stimulus package. So the point of the stimulus, the second round, is to distribute to areas that were more likely to be hurt specifically from COVID-19. And that's why that estimation in the portal is so important. It's not a perfect system.
Yeah, that is true on that issue, but unfortunately, what they are looking at is the March income and April. As you mentioned repeatedly, we don't see the losses until May and June. Of course, we are seeing in April, but you collect what you did in March in April. So that's not a very good formula, but that's what they did.
So I do want to comment on that point, because I know what my hospital network did here in Dayton, Ohio, because they're cognizant of that fact as far as gross collections. And what they did was an estimation on potential collections through the month of March or April. So to calculate their expected loss, they looked at the number of claims that they processed in March of 2019, for example, and then looked at the number of claims that they're processing in March of 2020 and said, we expect the delta to be this amount. So what they did was not estimate their gross collections for the month, but actually estimate their gross collections based on the actual claim in March, if that makes any sense. So because if you do what Dr. Montacani had mentioned, then what you do in March is reflective of what you actually practiced in January or February. So the way our hospital did it was just look at the number of claims they processed and said, well, based on the fact that we've had an 80% decrease in processed claims, we'll have an 80% decrease in revenue compared to the prior year, and this is our loss calculation. It doesn't really, it asks for an estimation, and I suppose that's an estimation. So if you're going to fill out the portal on how you do it, that's probably a way you want to do it, and it seems defendable based on the way the rule's written.
Yeah, I agree 100%, Amol.
Okay, we have an interesting question. Everybody is facing this. We want to extend the audio only or telehealth codes, But then the question is, I have a chronic pain patient who is supposed to follow up in a month, but requests another telemedicine visit instead of the office, as I planned for all patients. Is there a projected end date for allowance for telemedicine reimbursements? As of now, it is June 6th. We are asking them to extend through August 6th. Apart from that, I think telemedicine is still preferable. Right now, we are 50% of our visits are still telemedicine. We just opened on Monday in Kentucky, but it is still a good way to continue care. The question becomes again, why are you seeing them so frequently? If you saw them only a month ago, you have to document appropriate medical necessity and indications, then you will be fine. Comments, Amol, Shalini, Devi, Harold, everyone.
Sure, I can answer that. That's a great question. I think, first of all, it's impressive how much patients really enjoy the televisits. They're not looking for parking. They don't have to wait in line or wait in the office or wait in the waiting room. So from a patient satisfaction standpoint, it's also very beneficial, not to mention that it's sometimes more efficient of everyone's use of time, although it's harder to examine the patients, but that's a different point. Yeah, like Dr. Manchakanti said, June 6th is the proposed end date, so if your patient's coming in, hopefully will be coming in before that. But, even with opiate refills, it's totally reasonable to use telehealth. And as long as you document. The challenge that we're having is how do you do your due diligence, meaning your annual random due talks, renew your opiate contracts, things like that. That's something we haven't really figured out yet, though.
For us, when we talk to the patients, we've been kind of giving them a heads up that we also like telehealth just so they understand, they don't have to take time off work. They can schedule the phone call more conveniently or the video chat. And again, they don't have to spend time commuting, so their time is valuable. But at least we plant the seeds we're on the same side, but ultimately it's going to be up to the insurance companies and the lawmakers. So that way, even though we're doing the telehealth visits right now, if it works out and it continues, the patients will be happy with us. If it doesn't work out, then the patients won't feel that, oh, we're the ones who are making them come in and do all of this stuff. So at least they feel, like we're on the same side.
Okay. Anybody else? Any more comments? Well, we like telehealth, but again, once it passes June 6th, reimbursement will be pretty low, and all these relaxations on HIPAA and what you can use and what you cannot use, all those things are going to come back, and we will be back to where we were. Again, that will be another point of irritation, and you have to teach that person how to use the telehealth, and they recommend that a medical assistant call and teach them about it, at least in my community. So we have to see what happens. But a lot of people do like it because it is easy, and then even if they need a urine drug testing, then they won't have urine drug testing done because of the telehealth. They like things like that. So another question, Sam, related to telehealth, that's saying that we cannot use more than level 3 follow-up visit, which may not be true. You can use level 4 if you can document that there was necessity and complex medical problems and your medical decision making was moderately complex. But if you are doing only audio only, you have to use a different code. And this will go through June 6th. Anybody wants to comment on that?
You're correct. They can fill out a 99214. There's no limit to 99213.
Right. And some people are undercoding. They're billing I found several of our nurse practitioners were billing level 2. So next question is, do we need to screen every single patient prior to fluoroscopy/intraarticular injections, irrespective of the risk stratification level? again, it depends on your each state. That is what we are talking about. Like Illinois, you have to screen every patient if they are going to have any procedure, and they don't define what elective surgery is. Like if it is performed in a hospital setting or ASC, they don't mention the offices. They are pretty vague on that. So all our Illinois friends are watching this and they are trying to find out what will happen. So depending on your state, that is what happens. And majority of the states you do not. In Kentucky, we do not need to. We just have to follow national guidelines. So we follow the national guidelines according to risk stratification, what is recommended. Look at the risk stratification. And Tennessee, they do not have any such restrictions. And Amol will talk about Ohio in a few seconds. New York, everybody. So please go ahead and answer that. Amol?
Yeah, there's definitely state-to-state variability. So Ohio just opened up yesterday. In our state, you have to have testing available, but you don't necessarily have to test. If your question's about screening, and you said, okay, what if it's a very simple procedure like a knee or hip or shoulder injection? Do you really have to go through the algorithm and see as far as testing goes? And even that actually varies from state to state in terms of what they want and allow you to do. But let's say you're in a state that's opened up for procedures. How do you go about that? The one thing I would suggest is to look at the ASIPP toolkit that we made. There's a risk disclosure form and an informed consent form that you could use if you'd like to inform your patients of the increased risk. And you can go through the risk stratification flow chart and algorithm. So if it's an elderly patient or say they were in a nursing home, obviously they're going to be in a high risk category. If they have comorbid pulmonary conditions, they're going to be in higher risk category. But if they end up in like a lower or moderate risk and it's a low risk procedure, then there's a pathway forward for you. In fact, in the ASIPP toolkit, even if it's high risk, there's still a pathway forward to do procedures, but we do ask that you take mitigation steps to risk mitigate to your patients. And what does risk mitigation steps mean? Well, there's simple things you can do, right? Social distancing in your office, assessing and screening your patients for temperature, symptoms of, COVID, recent interaction with people who have had COVID, recent travel history, and whatnot, and take that into consideration and document that in your chart. To see if it's worthwhile to proceed doing the procedure. So I suggest to look at your state first, assuming you're allowed to proceed with procedures, to really do take a look at that ASIPP flow chart risk stratification toolkit, as well as consider using that informed consent form. At the end of the day, just use your best judgment, assuming your state allows it.
Actually, if it is just screening is a mandatory thing. It is not like whether you do a procedure or not. In my opinion, every employee and every patient who enters the building where you are going to be exposed, you have to screen them with questions if they have traveled, so on and so forth, or if they are running fever. Otherwise, that is a mandatory thing. Shalini, would you like to answer that question further?
No, I think you said it right. It's totally dependent state to state. In California, our governor has not opened up until May 15th, so that's going to be different from other states. And again, it was a federal mandate to open up as long as there's a gating process in place. And the gating process based from the federal government was that there's adequate testing and adequate PPE in place, and the hospital or health system has adequate availability for ICU beds should a second resurgence occur. So those are the gating processes in place that need to be met before a state governor can even open up a state to surgery or elective procedures. Assuming that those are met, then you can, it's up to the governor based on what he recommends on testing or not testing prior to procedures.
Okay, next question is, do we get a second HHS check automatically, or we need to apply? You have to apply for it and estimate your losses utilizing some kind of phenomenon. The next question is, will the fellowships in pain management continue as they are they going to be terminated because of the crisis, Shalini?
So the fellowships are not in crisis. The ACGME has posted on their website that accredited fellowships will continue as planned. There are a few considerations, though. You know, there's going to be massive migration of fellows and residents in the next month or two as residencies and fellowships start in July. And so one of the questions is, as part of the onboarding process, do we recommend that those residents and fellows now get pre-op testing or pre-onboarding test or screening processes? So there's a lot of unknowns that the ACGME hasn't answered, and I think they're relying, or they are deferring most of those answers to the institutions themselves. But the funding for fellowship and residency programs has not been addressed by the ACGME, and I don't think that's going to be an issue.
So does the funding for fellowships come from ACGME, or where does the funding come from?
It comes from CMS dollars, but as of right now, we haven't heard that any fellowship or residency program is going to be affected by not having funding.
Okay, thank you. Next question is, what is the consensus? What is the consensus in reference to, this is another question, but they're all asking the same question, covering all the equipment and also waiting between for cleaning the equipment time, etc. Shalini, would you answer that?
Okay, good. So if you are in an ASC, it all depends on your air changes per hour in your ventilation system. Most viral particles can be cleared within 18 minutes, but again, it depends on your ventilation system. Assuming you have normal ACH, which you can find on the CDC website, and they'll tell you based on your ACH, air exchanges per hour, how long you have to wait before bringing in the next patient. In terms of cleaning, from what I've read, the recommendation is to use alcohol-based products and not anything more specific than that. So I don't think there is a specific rule or regulation about the cleaning products, but there is definitely about bringing in your next patient for OR turnover for anesthesia cases.
Okay, next question is, could you assume every patient has COVID-19, especially in high prevalence states, and test with rapid test like Abbott gives results in 15 minutes before sending the patient in procedure room? Well, actually, in my opinion, Abbott testing will be good if you can find it. If you are in a state where it is high prevalence, you can get the Abbott testing, but remember, you can only do one test on one machine, which takes, I think it takes longer than 15 minutes though. If you have that, that would be a pretty good idea, or they can come day before and have the test done, and it also depends on the availability. We ordered them, we are hoping to get them. So maybe you want to answer that from New York?
Well, I agree with you. I mean, for us, it's hard to get a lot of these tests. And so far, I haven't seen a mandate that we have to test the patient. So we're going to probably do the regular screening. And then if we find that we can get reimbursed, like if we can get the test and get the reimbursement, then we may try that. But I think if you have the test like you suggested, it sounds like a good approach.
I know that
there is another comment on the same thing about saying that about, we can answer both of them together, that in one of the states, in Louisiana, they are paying only $20, and the cost of the test is much higher than that. How do you cope with that? Okay, now both questions can be answered together.
This is Harold. So I know the Cleveland Clinic in our local area is testing every single patient with rapid tests. So certainly it's going to depend on what the hospital policy, the ASC policy is, and what your policy is. And certainly the availability of those tests, they're really difficult to come by now. So, as of this point in time, you're not going to be able to test every single patient because you just don't have the access that you want. But in in the future, it may be, your policy, or depending on where you're doing your procedures, they may set the policy and not you.
Okay, any other comments? Okay, next question or comment, good news for West Virginians. West Virginia is requiring only clinicians wear a mask, nobody else. So Kentucky requires that we need surgical mask every time we do a procedure. Otherwise, you have to give a mask to the patient if you don't have one. I think Tennessee does the same thing. They have to have a mask. If they don't, you have to give one. Okay, then there is another question about what if the estimated loss was disproportionately underestimated due to misinterpreting the question? Is there a way to correct the mistake? Amol and Harold.
I'm not sure I understand what the question is asking.
So yeah, I think it was for the second part of the HHS loan, and it's a good question because I'm sure a lot of people misunderstood that estimation of loss rather than directly. If that money is going out yesterday, today, and then 95% by Friday, it may be a little too late, but certainly I'd encourage you to contact them and see if there's a way you can correct that mistake, but you better do it really quickly because most of that money's on its way out. So that's all I know.
Okay, next question is, can I still apply for the second HHS stimulus check? Is there a deadline?
You can still apply, yes. There's not a deadline, but once the money runs out, like the payroll protection program, you're not going to, get any. So obviously the sooner you apply, the better. I do know of multiple physicians who have already gotten their second wave. And I think it definitely correlates to people that I know that were quick to apply. And one thing I want to tell you that I'll just put up here on the slide, you can see, if you Google CARES Act Provider Relief Fund, HHS, it'll take you to this link that I have here on the second line of the slide that should be on your screen. And that is the link to the general distribution portal that you click and then follow those instructions.
Okay, we are running out of time, so we have time for one more question. Well, okay. Is there any role for using ultraviolet light for disinfecting procedure room between patients as well? Any recommendations on that, Shalini?
I haven't seen any recommendations on that. Yeah, I don't know. Like I said, alcohol-based cleaning solutions seem to be what's recommended right now in procedure suites, in IRs, in ORs, in hospital beds, and that should be sufficient.
That's great. That is a politically correct answer. Otherwise, you will be on TVs.
Yeah, it would take a really long time. It would take a very long time for UV light to disinfect the room. But you can also use bleach-based products, and there's a whole list of CDC cleaning agents that are approved for COVID-19. So they have specific regulations and specifications on each of those products on how long it needs to stay on the surface. So if you go to the CDC website and look up approved cleaning products, you'll see that there was like Cavi wipes. A lot of people use Cavi wipes, and there's about 4 different Cavi wipes. 3 of them are approved for COVID-19, and 1 of them is not. So you just got to be careful with that.
Okay. Thank you all, and I want to thank everyone for attending these seminars, webinars. We have had excellent attendance, and I think as Sunny has been showing, and Amol, and we have been showing repeatedly that we have done everything possible to help our membership and non-members and everyone. And we also have the special COVID issue. And yesterday I thought we didn't have many articles, and today we got 15 of them. So there are multiple articles on this. Preferably it is 3 pages or so, but even 1-page commentary is fine, Devi. And we can write on any subject you want to. And as we move on, we are all available. All our phone numbers are available. Emails are available on the emails on our website. Please keep in touch. And if you have questions, call us and use the guidelines, etc., to the best benefit of yours, all of you. Thank you again. Good night. Thank you.
Thank you, Dr. Manchikani. I'm going to go ahead and send out a quick survey, so we appreciate that you would fill that out, and thank you again for the attendees and the wonderful presentations. Have a good night.